patients have to give up some, or there's a risk of dying, and no one dies from Crohn's disease, so it's probably not the right tool to use. But what was interesting in this study was when we asked them qualitatively about taking 5-ASA, 45% in this study state that they did not value a 15% reduction in the risk of recurrence and preferred no medication. We then went on, and this work was done by Erin Kennedy, who did a PhD with me, and we used a much better instrument, and that is the probability trade-off technique, which measures patients' preferences for treatment. It's been developed and validated by Hilary Llewellyn-Thomas and Annette O'Connor. And what it allows us to do is find out what the MCID is. And what we mean by that is the minimal clinically important difference that patients think is important. And so that in this study we compared the minimum difference in the treatment effect size between two medications that a patient considered important. So we just used a convenient sample of 160 patients with Crohn's disease. We interviewed them with a standardized interview. It's a little bit outdated because we did this a few years ago, but the concept I think is still really important. These are the medications that we considered. We estimated that the risk of clinical recurrence was 25% at 1 year. We asked an international panel of experts, expert IBD gastroenterologists, what they thought was a reasonable risk reduction with these various medications, and I'll show you what they thought were the reasonable risk reductions. So essentially here, this is how the standardized interview would go. In this scenario that we used 5-ASA for the reference versus fish oil, and these would be what we would tell them is that what it would entail, the minor side effects, major side effects, and then what we would do is ask them to see how much of a risk reduction that they would want. So for instance here, and using the example of 5-ASA, where we had calculated, or for this, that we gave them a risk of recurrence with 5-ASA at 1 year was 15%, and this individual said that if the risk of recurrence with fish oil was only 10%, that they would choose fish oil over 5-ASA. Sorry, I've got that just a little bit mixed up here, that they'd want a 10% risk of symptomatic recurrence, that the MCID would be 15% minus 10% or 5%, meaning that they would want fish oil to be 5% more effective than 5-ASA before taking it. Okay, so this is a little bit of a busy slide, but on the left you can see the 5 medications that we looked at. And the first thing that I'll point out is in this column. And even though patients, or none of these medications would be of any benefit, about 10% of patients still said that they would want to take that medication, which doesn't make any sense to us, but you know, it's sort of hope springs eternal, I guess, that, well, if I take something, maybe it will work. And you can see here that about 30% of patients would take these medications, with the exception of Flagyl, if it decreased the risk of recurrence by 5%. So that was, our target was 25%. If it went down to 20%, about 30% of individuals would say that they'd want to take that medication. And you can see that the variability in patients wanting to take medication, it's quite variable across. And if you look at the last column, that before, even if the recurrence rate was decreased by 20%, so from 25 down to 5%, still only about 80 to 90% of patients would take post-op maintenance therapy. On the other hand, you can see here at the bottom is this is what our experts thought what were the realistic effectiveness of these various medications. And our experts said that Imuran, that they thought that likely that Imuran would decrease the risk of recurrence by 14%. Probably too generous, but anyway. And even if at that, only 45% of individuals said that they would take Imuran. And you can see for the others that it was much lower. So when I first presented this study, again to gastroenterologists, one of the gastroenterologists, who's very esteemed, a senior gastroenterologist in New York, in fact, said, well, I don't know why you're doing this, Robin. I tell my patients, I give them a prescription and I tell them to take it and they just take it. Well, I would say that we may be fooling ourselves, that they may not be taking medication that we take, that we prescribe, and why this is important is it's important, obviously, in looking at compliance with medication. When we ask patients generally that in choosing maintenance therapy, the side effect profile was the most important. On the other hand, effectiveness was the most important consideration when choosing treatment for active disease. But as you can see from the real variability, some patients would prefer the more effective but more toxic medication, whereas others stated that they would prefer the less effective but less toxic or fewer side effect medication. And when we did a logistic regression model, we failed to reveal any significant predictors. And we put a number of disease-related as well as demographic variables, and we could not predict who would choose what. So my view on maintenance therapy is that there's some evidence that 5-ASA, metronidazole, Imuran, and even infliximab may decrease endoscopic recurrence following surgery in short-term trials. However, how do we measure whether maintenance therapy is really effective? I don't think we know. Does maintenance therapy alter the natural history of Crohn's disease? I'm not sure that we know that. How do we identify patients who might benefit? And then what are patients' preferences, and will patients be compliant with maintenance therapy? And I think that's an issue that we need to look at. So I'll close and I'll say that surgery is very effective in treating the complications of Crohn's disease and improving quality of life, but recurrence occurs frequently and impacts negatively on quality of life. Surgical resection of all the macroscopic disease is the preferred option in most situations, but unfortunately there are no specific maneuvers that decrease the risk of recurrence. I feel quite strongly that patients should be advised to quit smoking to decrease their risk of recurrence. There's some evidence that maintenance therapy is effective in decreasing endoscopic recurrence, but its value in altering the natural history of Crohn's disease is yet to be determined. And I'll finish and just say thank you, all of you, for inviting me, and particularly to Peter and Ellen, and it's been great to be here and I've thoroughly enjoyed it. Thank you. Yes.
One of the situations that I don't think we see a lot of, but when we see it, it's very difficult, are people who seem to have fistulizing or sort of stenosing disease limited to the anal rectum. They seem to be fine everywhere else. We have a lot of anal perineal disease. Are you guys seeing that in Toronto too?
Yeah, we do see that. I think, though, that Peter asked, or maybe Peter or Ellen asked me that, I can't remember. I think in most of those patients that if they just have a stenosis, that the stenosis often isn't a big problem, but the perianal disease itself, so the fistulizing